Blog Talk Radio. Welcome to Medicaid Matters, the only live talk show about the business of Medicaid healthcare. And now, here's the host of Medicaid Matters, Richard Yaden.
And thank you, Braley, and good afternoon to everyone. I'm Richard Yaden, President and CEO of Managed Medicaid Services and the host of Medicaid Matters. We're very happy you're here to join us for the next hour. We're here every other Tuesday to bring you the best in Medicaid business topics, the topics that concern you the most. And this show is about you. It's about your ideas, your innovations, your challenges, and solutions to delivering care to those who need the help the most. Well, we're live today, broadcasting from our offices near Nashville, Tennessee. But the real excitement today is taking place in Washington. As you know, the Supreme Court is hearing arguments about many of the aspects of health reform legislation. I think their final ruling could have some tremendous implications for Medicaid. Yesterday was when the court began the deliberations and the hearings, and not a whole lot came out of yesterday from what I've been observing and listening to. It seems like that the justices are very reluctant to have to wait until 2014 to decide on the case that's before them. I know that is the administration's preference, but not quite sure how that's going to shake out. But you know, the most of the talks and deliberations yesterday were regarding the individual mandate. Today, I believe Medicaid expansion is on the agenda. As you know, 26 states have filed legal action against the law's expansion of Medicaid. Some of the lower courts have ruled in the administration's favor on that, and a decision about that is expected in June, and you can believe that we're going to be on top of that here as well when that comes about. I'm sure we'll have some guests after that ruling is decided and talk about that. We're also going to hear a few comments from our guests today in just a few minutes. And we'd also like to hear your comments about the Supreme Court hearings or anything else going on in Medicaid. That's one of the unique aspects of our show. It is interactive. You don't have to agree with me. You don't have to agree with our guest. But if you have an informed opinion or a comment, I know that our listeners would like to hear from you. The easiest way is just to give us a call. You can call us at 626-657-2125, and you can call starting right now. We'll take calls throughout the show today, and you can join us here on the air as well. You can also tweet a question to us if that's easier for you. You can direct it to @MedicaidTalk. And if you are up on Skype, as we are, you can send us a request to connect our two networks, our two Skype networks. And our Skype handle is Medicaid Talk. We're online right now, and we can certainly take questions from you that way as well. I also want to warn you, as we get into this broadcast, if you hear my voice failing or fading somewhat, here in Nashville, we are having a pollen outbreak of biblical proportions. I don't think there's a soul here that is not affected by it right now, yours truly included. So we're going to get through this, hopefully, the best we can. Well, with us today is a very interesting individual, someone that I know you're going to want to hear from. Robert Mendonsa is the CEO of Aetna Better Health in Illinois. And Robert, we're very happy that you could join us here today. Welcome to the program.
Well, welcome, and good afternoon and good morning.
Thank you. Well, let's before we jump into our topic today, which is going to be about integrated care management, why don't you tell our listeners a little bit about your background and your involvement in Medicaid?
Sure. Well, thank you. And so I had a long career with Aetna. Actually, I spent 20 years with Aetna. The last 8 I spent as a regional president, and really my background is on the commercial side. I retired from Aetna in February of 2010, and really to pursue something that I had been thinking about for a while, and that was a career in the nonprofit sector, specifically around social service organizations. So I was fortunate that I was hired in July of 2010 as the Chief Financial and Administrative Officer at a very large community mental health center, actually with a variety of services that we provided. We had alternative high school, a center for working families, and what have you. But I really saw firsthand in that role where the Medicaid, many of them, we had a big Medicaid business, and it was extremely helpful when Aetna approached me in October to come back and lead this initiative in Illinois. And I will tell you that as I learned about the integrated care program, which we'll get into, where the program clearly is focused on providing the support for this very vulnerable population and improve the quality of their lives. I just thought that this was the right program, and so it was a bit of serendipity that I had that great experience. But so I'm relatively new to Medicaid. I'd been with the plan. I came back in January of last year, but again, that experience continues to inform our strategy as we implement the integrated care program here in Illinois.
Interesting. And outside of your professional work, I know you've been involved in a lot of community activities on a volunteer basis. Isn't that correct?
Yes, I have. I've been chairman of the board of a for-profit free clinic serving the uninsured, very involved with the American Heart Association and others. So, yes, it's something that I feel strongly about, that we need to take care of those people that can't take care of themselves.
Yeah, very much so. Very much. Well, we're going to talk today about integrated care management and specifically about what Aetna is doing with that in Illinois. But before we get into that, I think our listeners would be interested in hearing some of your thoughts and your perspective on the Supreme Court's look at the health care legislation, especially as it might pertain to Medicaid expansion. So, for instance, we all try to have a crystal ball, and I don't think anybody's going to get it right this early in the process. But say they do strike down the state's requirement for Medicaid expansion. What do you think that's going to mean?
Well, if they do strike it down, obviously it'll have an impact. But if you think of Medicaid, that it's obviously going to impact the amount of people that we can get off of uninsured. I mean, it really comes down to do we really want to reduce the number of uninsured, because there is a social cost towards these people that are uninsured. They are getting care, they're not getting good quality care, and I would maintain that I'm not sure we're really going to be saving in the long term, because I think what we have to do is get people onto the system, promote quality, so that they will get the better levels of care, because there's other pieces in legislation that are really focused on quality around accountable care organizations, which is really trying to coordinate and integrate so much better our health delivery system. So if you take all the pieces of it, I think we've been missing a real opportunity to truly impact the health care in this country, improve quality, and reduce cost.
Mm-hmm. Well, certainly I have long advocated that Medicaid is probably the best infrastructure that we have available today to help more people get care. I guess the argument here at the Supreme Court is the federal government actually mandating that states expand it. So I guess
right.
I agree with what you're saying, because I think in the long run, the more people we can get into a quality care organization of some sort is going to overall bring the cost down. And that really kind of leads us to the topic of our conversation today, which is integrated care management. And as the head of Aetna Better Health there in Illinois, I know that you're very involved in the day-to-day operations of integrated care management. I know every plan president that I've ever met with or spoken to has an involvement in it, but I think you take a very much more of an active role in this. So tell us about how this works in your organization.
Sure, sure. Well, Aetna Better Health is a wholly owned subsidiary of Aetna. So it's a company called Schaller Anderson that had been in business with Medicaid for over 20 years. Aetna purchased them 5 years ago, and really has kept this organization, left it alone, knowing that it is so different from the commercial environment. When some of my former associates ask me what's the similarities between commercial and Medicaid, I like to tell them, well, we pay claims and we have members, and there the similarity ends. So so the health plans come up basically to support this. Every state is different. So what we build in every state, by its very nature, has to look differently. So we've taken a decentralized approach. Now, we're supported in terms of system claim payments centrally, but in terms of what we do here locally, we truly do build a health plan. So I view myself as I've just built a small business. We've hired 85 employees. In our health plan, we have a provider services team that deals with our providers. We have a member services that takes calls, that does outreach. I have a utilization management department, and also have a care coordination, and I'll talk a little bit more, because that's really the heart of this program. But it really takes, and especially with my role, is getting very involved in building the small business, but also in getting out to the external audiences, because as get into in a little bit, there were a lot of people who were distrustful of this program, a lot of misinformation. So we've had to do, and then there was the whole issue around the network build. So you really have to be hands-on, roll up the sleeves, talk to the providers to get them to sign, talk to the advocates to make sure they understand, and also building within our organization, make sure we have the right metrics. And so it really does function as independent businesses, and but also makes it really fun.
Well, take a minute and maybe describe the scope of Aetna's operations in Illinois, because it is a little bit different than maybe a plan that just comes in and bids on an RFP and gets assigned a membership group.
Yeah, this was, so we went live on May 1st, and the way that the state did this was they layered in the membership over time, and I'll talk a little bit about that. So let me back up. So this program is for, it's completely solely age-blind disabled, and it's in suburban Cook. So for those of you familiar with Chicago, it's not Chicago City proper. So so Chicago is in Cook County, but they're not included in it. So it's the suburban Cook. And then there's 5 collar counties: Kane, Kankakee, Lake, DuPage, and Will. And so the state identified approximately 36,000 ABD beneficiaries that got auto-assigned to one of 2 plans. So we are offered alongside Illini Care, which is a subsidiary of Centene. Mm-hmm. And there is a client enrollment broker that is responsible for if members don't voluntarily, so they could voluntarily choose one of us, but if they don't, then they are automatically assigned, and the auto-assignment rate is probably about 75%. So a very high percentage of these members were assigned to us. So we now have, we started on May 1st of last year, we had 300 members, and then that went up to 1,100, and then the first auto-assigns came in July, and that's when the membership really started to ramp up. So we went up to 7,000, and then 14. We're now up to 18, which is the final enrollment between the 2 plans. We've hired 85 employees, which I mentioned earlier, and they're all located in downtown Chicago. We are all co-located, so I think it's really important, especially when you bring up a new health plan, creating a new culture focused on providing these support services to these very vulnerable members. We felt it really important that the team all stays together, so we are coordinating amongst ourselves as much as possible, and we spent a lot of time on that. And the other thing is, it's important to keep in mind that of that 85 employees, 35 of those are directly for care management, for care coordination. So, this program is very simply about improving the quality of someone's life. So I use the example of someone who's homeless, that has HIV, AIDS, and is seriously mentally ill. So that person could be costing the taxpayer, the Medicaid, $1 million a year, and that's not unrealistic. Going into the ER, readmits, and someone could argue with a very poor quality of life. What this program aims to do is, number one, identifying when they're in the hospital and going in and finding them. So we have people who are on the street, face-to-face with members. We understand the resources available in the community for these people so that we can find a shelter for this homeless person. We can find them food. We can make sure that they start to stay compliant with their meds. So we try to build a working relationship first and foremost. But really what we focus on through the working relationship is to try to get these members into some form of resiliency so that they can treat themselves, stay on their meds. So this individual that I mentioned that was costing $1 million, I maintain with this program done right, we could keep this person stable, safe in the community, compliant with their meds, and this person could cost well under $100,000 or even $50,000 a year. So you've then dramatically improved quality and dramatically reduced cost. And that's kind of in a nutshell kind of the scope of the operation. So it's really care coordination is the focus here. Very different from commercial where it was sales. I have no sales force because people are all auto-signed. We do no marketing.
Right. Well, we're going to hear more about this as we get into it. We're going to take a quick break here for just a couple of minutes. So when we come back, we're going to talk a little bit about how this approach to integrated care management might be a little different in Illinois than maybe it is in some other states. So stay with us.
Elevating the quality of care with less cost. Today, that's the job of every Medicaid managed care company, but it can't be business as usual. Companies have to coordinate care a different way. The solution is managed Medicaid services. Through our virtual case manager network, our teams of Medicaid assessment specialists, and our new Advanced Care Transitions program, companies can dramatically raise the quality of care without increasing their cost. Visit us today at MedicaidServices.net. Managed Medicaid Services, your best source for innovative care management.
The Medicaid landscape is changing fast, and that means challenges. But it also means opportunity. Opportunity for you. And that's why you need to visit MedicaidJobs.net. MedicaidJobs.net is the place to showcase your talent to Medicaid companies, search for jobs, research the latest career trends, and register for the free Career Optimizer service. Don't wait. Go to MedicaidJobs.net today.
And welcome back to Medicaid Matters. This is the only live and interactive talk show about the business of Medicaid. I just want to take a moment here real quickly to speak to nurse practitioners who might be listening in today. The opportunities for you are growing in Medicaid and in Medicare. You might want to call our offices today. We hear about some exciting career developments that are going on and that are available for you right now. MedicaidJobs.net is also a great place to find and research Medicaid career opportunities. They're a sponsor of our show, and they're also a very useful resource to Medicaid professionals. So go there today and see what you might be missing. Well, we're talking with Robert Mendonsa, CEO of Aetna Better Health in Illinois, about integrated care management. And Robert, I think that from what I know, your approach there in Illinois and the program that you're a part of might be a little different than maybe what is going on in other states. I mean, I've heard it 100 times on this show. If you know Medicaid in one state, you know Medicaid in one state. So tell us a little bit about some of the differences of what you're doing than maybe what people would typically see in a program in another state.
Yeah, that's a great question. I think one of the primary differences, the way they've done it in Illinois, is virtually nothing is carved out. And that's actually very important. So in other states that we're in, for instance, some states will carve out pharmacy, some states will carve out behavioral health, some states will carve out the long-term support services. Here, everything is all in. So it really allows us to completely, and when I talked about earlier that the success of this program is about improving the support system for these very vulnerable members. I mean, the reason a lot of these members are where they are is that their support systems have failed them. They don't have any support systems, and so how do we reconnect that? So when we have the behavioral health component, which is very important in this population, we're finding 60 to 65% have some sort of mental illness as a diagnosis. Pharmacy is extremely important because it provides very much real-time information to really get ahead in finding the members that we need to that we need to help, and then having the long-term support services really completes the picture. So we have the complete view of the member because it's not just the psych, it's not just the medical, but the social is a really important impact here. You can't get someone to change their behavior and comply and start to do the right things from a medical standpoint until you reach them where they are. And one of the examples I use often is a woman who's a diabetic and overweight. If she's worried that her son is missing school and is potentially going to join a gang, as an alcoholic mother, and a variety of other issues, what we have to do is address that before we can get this woman to start to take care of herself and treat her diabetes. And that's really what's different about this program, that it really encompasses everything, so we can have the total view of the person.
Yeah, I think that's a trend that you may be pioneering there, but we're hearing more and more about how it's not just delivering care from a medical standpoint. There's a whole social aspect to it that has to be addressed. Because many times, if it's not, that's a barrier to that member of getting any care.
Without a doubt. I would say, for this gaining the trust of the members is probably one of the biggest challenges we face. I know we'll get into that, but it's so you've got to start with that trust. But this woman that I just described, until you can start to get her help with her son, help with her mother, and all these other things that are worrying her, she's not going to be even willing to talk to you about what she needs to do for her diabetes. So you're exactly right, Richard.
Yeah. I think every organization that takes on a new Medicaid marketplace, everybody has a great plan on paper, but the reality of implementation, and I know this because our firm gets involved in a lot of new plan implementation work. The reality of that is very apparent when you get into it. How have you had to take that plan and adapt to some of the realities of Medicaid in Illinois?
Yeah, I'd say the harshest reality that we had to adapt to was, managed Medicaid has a checkered history here in the state. It's been many failed attempts at moving membership into managed care. I mean, this state has not moved at all in that direction, and the provider community is also very strong and was very, really didn't like Medicaid payments, don't like managed care, and really, in some ways, distrustful of the state. And so you've got these three things going on that really was a perfect storm in a lot of ways, that they were resistant for a lot of reasons to join this program. So we've been doing a ton of work to work with the providers to get them to understand that we're going to enhance their ability to treat these patients through our care coordination. The fact that, as opposed to the state, we're going to pay on time, and we're never going to pay less than Medicaid. And so, but early on, I'd say the prevailing attitude was, let's ignore it and it'll go away because it always has. And so when we kind of sat down with the state and said, look, to do this, we have to go live. We know we know that the network is not adequate, but unless the the provider community sees this as real, it's going to be really tough to get their attention. So so I said got to sign a contract and we have to go live, knowing that in our contract, we also allowed for a 90-day transition of care. So we knew, and what that means is we allowed every member to keep seeing their current physician, hospital, what have you, for a period of 90 days, which we actually subsequently extended to allow the network to grow. So we wanted to make sure we didn't have disruption. So that was kind of a cushion. But I will tell you that that it was successful because we were able to grow. I'll give you some numbers. So when we went live on May 1st, we had about 600 primary care physicians. That's now almost 1,900. Mm-hmm. We had about 1,800 specialists, and that's now almost 3,300. We had 29 hospitals, and that's now over 50. So again, that all happened as the providers kind of understood this was real, and then we and then saw some of the benefits of what we were trying to achieve. I mean, I spent a great deal of my time meeting with hospitals, providers, and any other group that would listen to us to describe what we were trying to achieve in this program. But that was probably where we had to probably spend a lot more time than we had anticipated.
Yeah, I think some of our listeners are aware that that I spent a number of years in the Navy and part of that time in special warfare. And I know when we go on deployments, whatever plan we had never materialized in the way we thought it would. And, a lot of guys in our unit got very adept at figuring out how to get things done with whatever was available. And I know that happens a lot in a new plan rollout or a new operation in Medicaid. Tell us maybe some of the ways you've had to kind of innovate beyond the master plan to accomplish some of your goals.
Yeah, we really, I say a couple ways. I mean, first is with the providers, we instituted a provider call campaign. So we actually started to track every member that requested a physician or other provider, and we very proactively reached out, said, look, we have this member that you're seeing, will you continue to see them? So that was one thing that we really had to do to try to promote that growth. So we were very proactive there. The other thing is that as we started to really deal with our members, and there was a high level of multiple comorbidities, many chronic illnesses, virtually most of the calls ended up having some sort of clinical issues. So we embedded a couple LPNs into member services to really help members find new, again, this is around the network. A lot of it was finding a new doctor, assisting them. It was really helpful to have someone with a clinical background to assist in that. The other thing is really dedicating our case managers to finding these members. I mean, one of the any point in time, we can really find probably 25 to 30% of our members. And so we really had to establish partnerships primarily, and again, this comes back to my experience with the community mental health centers, so we'll know if a member has been to a community mental health center. So we've established, we've attempted to really establish strong relationships with these entities. This is just one example. And so we're able to then hook up, if we know that they're going to this CMHC, now I am assigning a care manager to go over there and to establish a relationship with their care managers so that we can meet these members on a safe environment and start to establish that relationship. And then the other thing that we're also doing is really dedicating our care coordinators to our high-volume practices. And that's something we'd kind of planned for, but we're doing it and it's really helped because a lot of what's been happening with the providers is they've seen an influx of these members, whether the ones that signed up with us, they're seeing how sick they are. So what we have done is reached out and said, well, we will embed someone or dedicate someone to really help with that care coordination to take some of the burden off you, and that has been well received.
I can imagine that it is. Having those care coordinators, kind of at the point of contact in the providers, I think is a tremendous advantage, not just for the physician practice or the providers there, but also for you to really understand what's going on as soon as you can. Have you seen a a measurable increase in quality by having those care coordinators in there?
You know, we have not produced quality stats yet. I will tell you, I am of all people, I can't wait to start seeing them. I would say that anecdotally, I absolutely know we have.
Yeah.
We have tracked, multiple success stories where, there was someone that, they've lost their caregiver. It was a diabetic, didn't know how they were. The person was also blind, so we were able to actually go to their home, look at the environment, get them a home health, help them get their injections. I mean, we've had people that had multiple ER visits, and once we've intervened, have had that reduced substantially. So, we're all anxious to get the data, but at this point we don't have it. But I am confident that we will show the improvements in quality.
Well, great, and look forward to hearing about that as well. Well, it's time for a second break from our sponsors. Be sure to visit the Medicaid Talk community on Facebook. You want to be a part with us there. So stay with us. We've got a lot more to come.
You're listening to Medicaid Matters on the blogtalkradio.com network. Are you a Medicaid industry expert, state executive, or thought leader? Can you share a perspective about the business of Medicaid that's unique, innovative, or even controversial? If so, you could be a future guest on Medicaid Matters. We are currently scheduling guests, and it's time to share your big idea about Medicaid. Go to our website and send us a message. Tell us what you want to talk about and how we can contact you. Make your voice heard. Make Medicaid better.
Well, you can also be a sponsor of Medicaid Matters. It's not uncommon for several hundred people to listen to this program every single week. Each of them are professionals interested in the business of Medicaid and interested in your message. If you'd like to learn more about being a sponsor, you can email us at info@medicaidservices.net or call us at 615-257-1627. We're talking with Robert Mendonsa, CEO of Aetna Better Health in Illinois, and Robert is talking about their approach to integrated care management and some of the uniqueness of that in the state. Robert, it seems that more plans are reaching into and really trying to integrate community resources to engage Medicaid members. And this is beyond what we were just talking about before the break of putting care coordinators right in the provider, but I mean actually going into churches, going into advocacy groups and things like that. Have you found that that's something Aetna's needed to do in Illinois as well?
Oh, Richard, that is absolutely critical. We actually we have a full-time community liaison manager. And this individual's job is to really, she does work with the advocates, but also identifying all of the resources, the shelters, the meal programs, I mean, everything that's available so that our care coordinators can hook these people up to these support systems. It's absolutely critical. It really is. She actually also sits in. We have daily rounds with our care coordinators and our medical director where the care coordinators can bring up issues that they've had with some of the members, and our community liaison manager sits right there and is able to refer them to services. In addition, we have I've hired one of the local advocates who specializes in this kind of training on local resources to continue to train our care coordinators. So we feel very strongly about the importance of connecting people to community resources. And also we believe strongly that we want to invest more in those community resources. You know, if I think about this program, we want to reduce what we spend on readmissions, ER usage, give some money back to the taxpayers of the state, but also put that money back into the communities where I think it belongs and where we can enhance the quality of life for these people.
How have these community resources responded to that outreach?
I would say very well. I coming from working at a CMHC, I will tell you I love the people at the state. but I often like to tell these players that we're going to be a lot easier to do business with the state. You know who's in charge. We're going to pay. We're going to pay on time. So we've really tried to enhance that kind of relationship. So I would say that's gone very well.
Mm-hmm. Well, good. I think it's getting back to a point we were making in our earlier conversation. I think it's critical that you have that type of involvement because, as a plan, you're not going to be able to resolve every issue that member is trying to deal with outside of just their basic medical care. And having those community resources, it's just a win-win for the resources. It's a win-win for the member. It's a win-win for the plan. It's a win-win for the state and the state taxpayers. It's just
exactly. No, exactly. I mean, I would just say it absolutely is, and I would just say that we purposely are not going to replicate what's working in the community. So, for instance, we're partnering with an agency that has just wonderful homeless programs. They know how to find the homeless. They know how to. So rather than we recreate that, we're actually in discussions to hire them as our care coordinator. And we're also looking at other special populations where if there is an expertise in the community that exists, I'd rather use what's working effectively as opposed to recreating it.
Is that a policy of Aetna, or is that just something that because you've had to get it done, that's what you've come up with?
That's a good question. I mean, we've done this in other markets as well. Again, what we have to accomplish here, I just think it's real important, and that we identify those resources, find the ones that are really doing a top-notch job, and really support those.
Yeah, no question. We in our firm, we try to reach and communicate a lot of Medicaid members, or communicate with a lot of Medicaid members. And it's really challenging sometimes to do that. Have you had to innovate any new methods of trying to just get the word out to your members?
It's extremely challenging, Richard. I would say extremely challenging. As I said earlier, if I were to do a phone blitz of our members at any day, I'll probably reach 30% of them. And that's just the reality. So, as I mentioned earlier, one of the things that we are doing is really trying to partner with our community partners, the CMHCs, the shelters, and some of these others, to help us when they find a member to contact us, so that we can then start to work with them. So, we're learning as we go, but that is one. The face-to-face is absolutely critical. The other thing that we've done is when someone calls into member services, if it's someone we haven't been able to reach, the member services people know that, so they're able then to refer them over immediately to our care coordinators so they could do a health risk assessment, and at least we can start to get some information on that. So those are couple of the things that we've done, but this is a huge area of focus for us, and I think that it's a challenge. But we've actually able to start. We're actually been getting a lot better at finding our members. The other thing is my care coordinators have become quite the detectives. So we look at claim history, find out what pharmacy this person is going to, what's the last doctor that they went to, and find out if when's the next visit, and we show up. So there's a variety of things that we're doing to get effective at finding the members that we need to find.
Yes, that's a job in and of itself, just trying to get connected.
Yeah, that's exactly right.
Well, you talked about that challenge. I know that there have been other challenges as well as things have gone for you. I know there are always going to be other challenges. When you look over the past year, what have been some of your organization's biggest challenges that you've had to overcome?
Well, I talked about the network. That was probably the single biggest challenge. That's starting to get behind us. We've increased the network. Finding our members has been an issue, which I talked about. The other thing that has been a challenge is convincing them to let us help them. This has been a very unmanaged population. They're very skeptical. For some of them, the only powerful thing they have in their lives is their Medicaid card. And what have we done? We've taken it away and replaced it with a card that says Aetna on it. So we do have to spend a lot of time helping to educate them. And the other thing is spending a lot of time with the advocate community, whether it's physically disabled, the DD, mental illness. We do spend a lot of time getting their support to other venues so we could get the word out about what we're exactly trying to accomplish, because we really are trying to form, if you think about it, Richard, that we don't have a healthcare system for these people. They are basically going to the ER. And I should also point out that, this, where someone's got great support systems today, so someone could be very sick and with a variety of illnesses, but if they're plugged in and got all the support systems, there's not much we're going to be able to do. Where really we focus is on finding that where we're going to have the biggest impact and identifying those people who are at the greatest risk as opposed to the greatest medical costs. So.
Right. Well, I think it could be argued that not just in Medicaid, but the entire commercial, private pay, whatever it might be, system that we have isn't really a healthcare system. It's more of a sick care system. But that's probably the topic of another show.
Yeah, I'm sure it is.
I just want to come back and circle around on the challenge that you had in building your network there, because it's something that I hear, I wouldn't say frequently, but often from our clients in trying to build their network. Why do you think that was such a challenge in Illinois?
In talking with my national, my other CEOs, but I'm come to that it's as bad here as they've ever seen. So we've built a lot of networks in other areas. I just think that the Chicagoland has never embraced managed care, even on the commercial side. I mean, we've never been over 20% HMO penetration in this marketplace. So there's been a long tradition of anti-managed care. So you couple that with I would say the Medicaid reimbursement is woefully inadequate, and I would be the first to recognize that. In fact, one of the things we tell the provider community is work with us because we know we need to pay you more. I just want to find the right providers, wring savings out so we could pay people fairly. So you've got that. And then I also mentioned that the state has been, I had providers talk to me about what happened in 1995, about some of the efforts to move into managed care that have really failed in so many ways. So yeah, those things all kind of conspiring so that, if I ignore it, it'll go away. It's reimbursement I don't want anyway. And you can also layer on, this is a very difficult population to manage. So it was really a variety of factors that did make that probably an incredible challenge for us.
Yeah, I'm hearing more about plans that are providing incentives for providers or physician practices that go beyond just the reimbursement, that hit certain marks of quality or engagement or something like that. Is that something that you're doing there as well?
We absolutely are. So with our contract for those, we have to spend a minimum of 88 cents on every dollar on direct health care. And I'm often asked by legislators, so Aetna, why are you in this? And so where we are potentially can make our money for Aetna is through quality. So there are 30 quality measures built into our contract. 14 of those are pay for performance, so we can own a bonus on. One of the things we've done is working with our providers. We let them select a subset of those, and we hold them accountable so that they can also get a bonus, so that we are lining up all the objectives. One of the measures that we do want all the providers to sign on to is a readmission rate, because we do know that's probably one of the biggest issues we've got. Our information is Illinois has the highest readmission rate in the country. Yes. The other thing we're doing is to promote medical homes. We have rolled out a program where we have tiered our medical homes, so we sent out a self-assessment to all of our PCPs, and to designate them as a medical home, and we stratify them into 4 categories. 1 being the highest level of PCMHness, if we have the term, 4 being the lowest, and we stagger the payments. So the highest payment at a level 1 would be, say, $7 per member per month, and the lowest payment at level 4 would be $7, and a level 1 would be $2. And my intent over time is the level 1 should go down to 0 as we promote. What we're really trying to do is promote these physicians to make the investments to move them up the medical home, because we really believe the whole notion of medical home integration is consistent with this program, and that we have to really build those capabilities, specifically having providers with mental health capabilities. That's really important here. And we're actually been looking at how do we make some of our CMHCs into medical homes as well. How do we give them some of the clinical capabilities that they need? So, yes, it's a very, very important part of this program.
It sounds like from what we were saying earlier, your challenge in building that provider network has been somewhat unique to your locality. And do you think that's something that's just symptomatic of a much larger issue beyond just a resistance to managed care?
I really do think it's unique here for Illinois, just because our the reimbursement rates are very low. The state is about 7 or 8 months behind in payments, and so I think there's just and again, there's been, the state has started with managed care and backed off, and but I will tell you today they're very committed to it. I think that the design of this program was extremely well done, very well thought out in terms of how we're incented, that it's really all towards quality. We're incented to bring doctors and nurse practitioners into the nursing homes, so that the nursing home residents don't end up in an ER. I mean, they really thought through a variety of details, but I think those challenges around the network, I mean, I mentioned that confluence of factors, and I think that, I'm sure there's other states that have similar factors, but I think those three were very pronounced here in Illinois.
Yeah. Well, to our listeners and our viewers, you just have a few more minutes if you want to participate in today's program and in this discussion. We'd like to hear from you either on the phone or through Twitter or Skype, and we'll be back here in just a few minutes with more from Robert Mendonsa.
I hope you're enjoying today's show, and I want to remind you that opinions and viewpoints expressed by guests on the Medicaid Matters Talk Show are not necessarily those of the host or our sponsors. Thanks for listening, and we'll be back in just a moment.
By providing access to the care they need and the quality they deserve, Medicaid health plans enhance health outcomes of our nation's underserved. Just listen to how a Medicaid health plan made a difference to Miriam.
I was 10 years overdue for my annual mammogram when my Medicaid plan case manager called and convinced me to just do it. The mobile mammography van my plan provided made it simple. Breast cancer runs in my family. That phone call may have saved my life.
Medicaid Health Plans of America, ensuring access to better health care. Learn more at nhpa.org.
Well, this is Medicaid Matters, the only live business talk show about Medicaid health care. We're here every other Tuesday, 1 p.m. Eastern Time. We're also giving away a free webinar access to the Medicaid Health Plans of America's new Best Practices series. Now, we've already given away one of these to one of our listeners, and you too can be a part of this by going to MedicaidTalk.com and registering for our blog. You register now, we're going to be drawing another winner later next month, and it could be you. So we hope to see you on there. We've been talking with Robert Mendonsa, CEO of Aetna Better Health in Illinois, about the integrated care management program that he is running in that state in conjunction with Aetna Better Health and a partnership with the state. Robert, you have obviously been in this up to your neck, shirt sleeves rolled up, digging into it, very knowledgeable about your marketplace in there. But, no one organization can do everything. Have you had to, beyond just community groups, but have you had to go to any outside resources to help you get the job done?
That's a good question. I mean, I would say a couple things. I mean, we do, as part of our requirement with the state contract, we have to spend a certain amount of funds on minority, women-owned businesses. So we do have some kind of unique partnerships there with one firm and we try to, look at their capabilities. So the one that we hired is actually, some of these are our care managers or care coordinators that with a specific expertise around knowing when to go into the community, about the home visits. So we've kind of tapped into that capability. But I think some of what I think is going to be the most exciting, as I talked about earlier, is really our ability to identify those providers of these services that we need, i.e. finding our members, dealing with their homeless issues, dealing specifically with members who have AIDS, which have a large and are very expensive part of this population. So we do know there's expertise in the community about dealing with that. So our strategy is to not replicate that, but where there is really look at the best practices and support that so that they can actually grow, and we're working with the best providers. So that's really been and will be a continued area of focus, because it's, and I say this all the time, but it's this success of this program is really reinvesting in the community resources, and that's really what we aim to do.
Mm-hmm. And that sounds like that's a policy that you have there, not necessarily something the state's mandating.
That's exactly right. Yeah, the state basically prescribed that we have care coordination. How exactly we do it, that was left up to us.
That's great. Well, good,
Mm-hmm.
good. Now, how long is the contract that you have there?
The contract is for 5 years.
Okay.
And there's 3 phases to it, and I probably should have mentioned earlier. So phase 1, we have all the medical, the pharmacy, behavioral health I mentioned. We also cover vision and dental. Starting phase 2, which would be the later part of this year, we'll be responsible for all the long-term support services, so all the waiver services, homemaker, personal assistance, all those kind of services. And then for everyone but for the developmentally disabled. And then the developmentally disabled waivers would be in phase 3, which we're anticipating for next year.
And your membership will grow as those phases come onto play, right?
They actually won't.
No.
It's the same people.
Okay.
They're just layering in additional services that we're responsible for. So that same 18,000 members that we have today, going into next year, the 1,500 or so that are on waivers will be responsible for those waiver services.
Now, why was the metro Cook County area left out of this?
Yeah, that's a great question. If you look at where the growth has come,
Mm-hmm.
in the biggest area of growth in Medicaid population, it really has been in that targeted area. It hasn't really been in Chicago. So again, I didn't make that decision, but just in looking at the facts as I see it, I'm sure that was a contributing factor.
Right. No doubt. Well,
and clearly for those in Illinois, Chicago is where the bulk of the population of Illinois is. So.
Mm-hmm. That's right. Well, when you look out, over the horizon of Illinois Medicaid and Aetna's role in there, what kind of things are you seeing?
Yeah, it's no secret that Medicaid is bankrupting the state. Right now, we're projecting about a $2.7 billion deficit, and that's off a $14 billion spend. So it's a big number. So we really are working with the state. We feel we can be a solution to preserving Medicaid benefits for these people, as opposed to taking the routes of cutting eligibility, cutting benefits, which is never going to get anywhere near that level of savings. So what we really want to be able to show the state, to taxpayers, is that if we can do 3 things: reduce cost, that we can improve quality, and these are going to be very transparent. There will be measures that the state will report on, and we're held accountable to improve on every measure. I'm going to stress that. So starting in year 1, I think we can miss on 3 of those 30 measures, but starting in year 2, we have to show improvement on every single measure. So that's the second piece. The third is the state is engaged the University of Illinois Chicago to do a satisfaction survey. So that they now have a baseline, so they'll be doing a satisfaction survey every year. So it is our intent to be able to show reduced costs, improve quality, and reduce and improve satisfaction, so we can continue to expand this program and save the state and the taxpayers money, and really save Medicaid in so many ways.
Yeah. Well, it'll be interesting to see how well they find everybody to do that survey.
Yeah, exactly.
So difficult. When getting back to the budget issue that you mentioned, and I know this is something that is going on in every single state, every single client is dealing with it. Do you feel like you've had to create contingency plans in case they do go the route of cutting benefits or membership, or do you really feel like that you're going to be able to demonstrate that there's not a need to do that by the results that you're achieving.
Yeah, I mean, I think there is a growing recognition that coordination of care is where the savings needs to come. Because if you just run the numbers on where you can cut benefits, where you can cut some eligibility, yeah, you can get some of the savings, but are you really? So you're cutting the savings out of Medicaid, but you clearly are not cutting the savings out of the system. And so I think it's this holistic approach that we really want to be able to show that if you really do focus on the whole person and really change the nature of the delivery system, that's where the real savings are. I mean, the real savings, Richard, is that individual that I mentioned who's homeless, has AIDS, and is seriously mentally ill that is costing the taxpayer $1 million. To the extent we can find these people, get them safe, supported in the community, and reduce that cost to, say, $50,000, that's where the savings, the real savings, needs to come.
Right, and we try to not be too political on our show here, but it's hard to escape politics when you're talking about Medicaid. So I'm going to ask you: do you, and if you would decline to answer, I certainly understand. But do you find the state is looking at things from that perspective, or is it just we're going to wait till the last minute and then make a decision?
I think right now, given the state of the Medicaid, I think everything is on the table. I think there's a lot of very thoughtful discussions. I don't think there's any consensus at this point, but I do think that there is a very robust set of conversations that really hadn't really taken place in the past. And so I think that sometimes the seriousness of this issue is really going to force what we hope to see is some real meaningful reform to really save Medicaid in the state.
If the Supreme Court comes back and says that states don't have to expand Medicaid in accordance with the legislation, how do you think that might change the discussions there?
I mean, we have 2.8 million beneficiaries in the state. With the expansion, that would go up to 3.5 million. So that's 700,000 that wouldn't be in, but 2.8 million is a big number.
Yes.
And there's a lot of savings to be had there.
Yeah, I'm hearing a lot of our clients, and I've certainly heard this over and over at some Medicaid conferences we've been to, that even if the Supreme Court does strike down the expansion, a lot of this is still going to move forward. There's just too much momentum behind that. Do you find that to be the case as well in Illinois?
Without a doubt.
Yeah, that's what I'm thinking as well. So, well, we're almost finished here. Do you have any other thoughts or any other comments you'd like to share with us before we wrap it up?
Yeah, thank you. The only thought I'd have is something I tell to the advocates and the providers that I meet, that we all know how to kill stuff, but this is really about building. And if you think about what we're spending for these people who don't have any support systems, it's a huge drain on. I mean, it's money that should be spent on schools, on roads, on a variety of other things, and it's so poor quality. And to the extent we can create something different, that we could work with clinical leadership in the community to change the way we practice, focus on these individuals that are costing so much. So it really is investing in the system, in a whole new system for these people. But I keep coming back to it's really changing the paradigm of how providers and the insurers. It shouldn't be adversarial. We're in this together, and I think we need to be transparent. We need to show that, but it's really how do we work together to improve the quality of these people's lives, and that's what we've really been striving to change. But it's a tough paradigm to change. The managed care organization has been at this for a long time.
Yeah, and that's what it's all about. At the end of the day, is how do we help these people? That's what it's all about.
Right.
Well, Robert, thanks so much for being on our show today. Maybe you could come back later 90
seconds
and update us on some of the things we've talked about today.
That would be my pleasure. Thank you very much.
Good. Well, if our listeners have been on MedicaidTalk.com, you've seen some things that we have planned. Our next show will be on April 10th, and we're going to spend some time talking about the Supreme Court arguments and any further developments that have come from that. Also, don't forget to go to MedicaidTalk.com and register for that MHPA's free webinar. It's a $150 value. Just sign up for our blog, and we're going to be drawing for that next month. And I hope to see you personally at the Medicaid Health Plans of America's award event on April 30th. We'll be there broadcasting live from the event, so if you can make it, we'd love to meet you and be a part of that program as well. Well, today is Tuesday, March 27th, 2012. This is your host, Richard Yaden. You've been listening to Medicaid Matters, brought to you by Managed Medicaid Services. And we'll be talking again in 2 weeks, so have a good time.
Seconds. Thank you for using Blog Talk Radio. Goodbye.